and we were working our way through the second first-line medication class, the ACE inhibitors. So this is about where we stopped off. So maybe a little bit of a rehash here, but we were discussing that as far as the ACEs go, or the ACE inhibitors, that we want to utilize those in our folks with some compelling indications, right? Diabetes with proteinuria, post-MI patients, if your patients had a stroke, high risk for coronary artery disease, and also chronic kidney disease because of the cardioprotective and kidney protective aspects of ACE inhibitors. We discussed that some of the literature currently and in the past mentioned that ACE inhibitors may not be as efficacious, have as much efficacy for African American population, but is still considered a first-line medication. As we move through, we will talk about historically the first-line classes that were taught to be more efficacious because of the possible decreased RAS functioning in the African American population. But the take home is that the ACE inhibitors are still considered a first-line medication. And do keep in mind that ACEs are still renally excreted. So we talked about bradykinin, where we left off Friday, the slide before this, and how with our ACE inhibitors, then the bradykinin isn't broken down. And that's what gives us our most common adverse effect in this class of medications, which is this dry cough. And you can see it's like up to like 40% of patients who are put on ACE inhibitors. So pretty good chance of that when you put someone on an ACE, they can develop the dry cough due to, we think, increased bradykinin, or it's actually a decrease of bradykinin being broken down. So it stays in the system longer. So the dry cough, we can switch our patients over to an ARB if it becomes too annoying, or we want to keep them on an ACE or an ARB, but they're having a dry cough. Okay, they can't take it. We'll switch them to an ARB. Unlike the other adverse effect, angioedema, and you can see the pictures of the patients there on the slide. When we have angioedema, we are going to avoid both ACEs and ARBs. The ARBs are not going to have the same risk for developing angioedema, but there's still a possibility. So if a patient develops angioedema on an ACE, we do not try them on an ARB. We switch them for the dry cough, but not with the angioedema, which is that swelling of the dermis, subcutaneous or submucosal tissue that you see on the pictures on the right, usually involving the lips, the face. It can affect the respiratory tract and can affect GI mucosa. So it's a rare, potentially life-threatening reaction. So if your patient gets angioedema, get away from ACEs and ARBs altogether. Also, other adverse effects in the class of ACE inhibitors, hypertension and some taste disturbances. So adverse effects, hyperkalemia. ACE inhibitors are going to cause hyperkalemia by reducing aldosterone levels primarily. We talked about their MEK action earlier in the RAS system on Friday, but when they're decreasing, when the ACE inhibitors are decreasing aldosterone levels, then the kidney's ability to excrete potassium is affected. So an adverse effect is hyperkalemia. Important to note that some of the kidney function tests, when you put a patient on an ACE inhibitor, they're going to rise, right? Up to 20% increase is acceptable. So you need to know that number. Board loves to test this concept that with an ACE, we got a 10% rise in our BUN or our serum creatinine, we got to switch them. No, up to 20% is acceptable, right? That's because of the reduced pressure within the glomerulus. So there's decreased filtration caused by the MEK action of ACE inhibitors on the kidney. So be sure you're aware of that effect when you get that first lab a couple of weeks or a month after you started a patient on their ACE inhibitors for hypertension, that slight up to 20% increase in serum creatinine or BUN is expected and acceptable. So a true contraindication is there on the slide, two of them. Renal artery stenosis, whether that be one side of the kidney or both kidneys. So if you have renal artery stenosis, either unilateral or a bilateral, it's a true contraindication to ACE inhibitors. Also, pregnancy, contraindication. So definitely be aware as we talk through all the first-line antihypertensives, if you can use them in pregnancy or not. We're going to talk about, as we get to some of the other classes, that pregnancy, we only have three main options. So I'll point them out. But ACEs is not one of them. ACEs are contraindicated in pregnancy. And as we mentioned on Friday, we have to check labs, right? Because of the MEC action, because of the possible adverse effect of hyperkalemia, we need to monitor. Usually we say within the first 2 weeks. Then we're going to, once we get our patient stabilized a bit, we'll probably go to once a month. And then once everything's hunky-dory, we'll start looking at things like twice a year, every 6 months or up to a year if a patient's been on it long term. So we want to look at the potassium because of the adverse effects. We want to look at the creatinine and BUN. And as it says there, for ACEs, usually about 2 weeks in. Almost as a general rule, we say a month, so I'm not going to get down to splitting hairs like that on your exam. The boards usually won't either, but the slide says 2 weeks because that's the packaging, but mostly we're going to say that as an overall for our first line medications for hypertension, when we put something on board, minimum at a month, we need to be rechecking their electrolytes and their kidney functions. So continuing on with the ACEs, like I said, pregnancy, avoid. Contraindicated. They can cause renal or fetal renal failure and skull hypoplasia and fetal death. So if you see ACE with pregnancy, you know it's wrong. Drug interactions are important. We talked about the adverse effects of ACEs. So other medications, and specifically diuretics that are potassium sparing. So if ACEs are going to cause hyperkalemia and then we put on another medication that's going to cause us or our patient to retain more potassium, well, that's when we're starting to get into hyperkalemia, and then we can get all those side effects, right? So then we can start talking about risk of those fatal arrhythmias or possibly even death. So we haven't talked about any potassium-sparing diuretics yet. We're going to talk those when we get into the diuretics classes, because at this point we've only talked about the thiazides, right? And are thiazide diuretics potassium sparing? No, because they would be in the potassium sparing class, not thiazides. So potassium sparing diuretics have their own class of medications. So know that the thiazides are not. So no real concern other than the hyperkalemia that can be caused from the ACE itself, combining it with thiazides with regards to potassium. Not true when we talk the other classes of diuretics. The renal trifecta, this will come up on your boards. If you see a patient on an ACE, taking an NSAID, and on a diuretic, you can get acute kidney injury. Right, so the renal trifecta, and I think the next slide actually shows it, but it talks a little bit to it on this slide there at the bottom. So when you start getting those three different classes of medications on board, the actions and the MEC actions that are listed there can result in drug-induced acute kidney injury. So the boards love to ask that, whether you're adding a diuretic for a hypertensive patient or you're adding an ACE and they're already on an NSAID for something else, the renal trifecta, that acute kidney injury, right? Because together, all these drugs can dramatically reduce renal perfusion. So if you see the creatinine's rising, your patient's on an NSAID, the BUN's going up, creatinine's going up, and we're seeing these three med classes on board, start thinking that renal trifecta. I think the next slide just kind of points out top left, normal perfusion. We're basically looking at the afferent and efferent arterioles, so showing normal glomerular filtration rate. And then top right, decreased perfusion pressure. What happens with normal maintenance of our glomerular filtration rate is if you get increased vasodilatory response to prostaglandins. On the other side, angiotensin 2 is going to counter it, and that's going to then maintain our normal glomerular filtration rate. But down on the left, when we get NSAIDs on board, now we're going to have decreased vasodilatory effects on the afferent arteriole, and then our angiotensin 2 is still functioning. And then we look over to the right is the presence of an ACE and ARB and what happens there. So with the ACE or ARB, the afferent arteriole is going to be slightly vasodilatory, and then we're going to have decreased angiotensin 2 function. So when you start combining those ACEs or ARBs with those NSAIDs and those two effects, that combination and now add on a diuretic are going to be what causes an acute kidney injury. I'm not going to ask you about the pathophys of it, just know those three classes and what they can cause if utilized together. But this slide is just to help you understand what's happening to the kidney itself to change the glomerular filtration rate by the drug classes. All right, moving into our next backbone drug class, the ARBs, angiotensin 2 receptor blockers. So they're in the same system, right? The RAS system as the ACEs. They're just hitting a different target, a different point. So when do we use them? Usually it's folks that can't take the ACE. Usually, now you'll remember on our slide, and we're going to hit it when we get more directly into hypertension treatment upcoming in this lecture, that you can choose ACE or ARB, but in general, if folks can't tolerate an ACE, that's when we're going to go to an ARB, right? Because of those compelling indications for an ACE. So normally that's going to be what? That dry cough. If the patient can't handle the dry cough, that's when we go to an ARB, because you're not going to have the same effects on bradykinin with the ARB because where it functions versus where the ACE inhibitor is functioning in the RAS system. If you remember where the ACE is acting, the ACE inhibitor, now we're talking all the way down at the receptor, right? At the angiotensin 2 receptor. So further downstream is where the ARB is going to be acting, right? Once again, we got our stars here. When we talk about the drugs from the ARB class that can be utilized in heart failure. Only a few of them there. So, and it says on the slide, star, key indicated for heart failure. Easy to pick them out of a lineup. They're all the ARBs end in sartan. So you don't have to memorize them. You just need to know which ones can be used in heart failure. And this is, like I said, preview of things to come, because we're going to have an entire lecture on heart failure. We're going to hit these and talk about why these medications are beneficial in heart failure. But just so that you're understanding, there are a few of the ARB class that are useful when you have a comorbidity of heart failure and with hypertension. So ARBs benefit, like we said, the bradykinin isn't affected, not hanging around as much as it is with the ACE inhibitors, so less cough. There is a chance of angioedema, but less than the ACEs. The drawbacks there on the bottom of the slide. Costs a lot, and there's not as much clinical data out there. So as I mentioned on the last slide, ACE inhibitor on board, patient gets that dry cough, can't tolerate it, switch them to an ARB. Angioedema, do we switch them to an ARB if they get angioedema from an ACE? No, we're moving into other classes completely because it can be life-threatening. So here's the MEC action. We already talked about it earlier Friday. So it's going to antagonize angiotensin 2 at the AT1 receptor. So AT1 is predominant in the vasculature. On the picture on the bottom right, you can see when you get the ARB on board, all of the reverse effects basically that happens at AT1. Decreased vasoconstriction, decreased aldosterone secretion, decreased catecholamine release, decreased cell proliferation, and decreased cell hypertrophy, all lowering the blood pressure, right? The AT1 receptor, when it is agonized with angiotensin II, when it's facilitated, all those things increase. So basically, when we get the ARB on blocking it, it reverses the vasoconstriction and the aldosterone secretion and catecholamine release. Same cardiovascular and renal protection from the ARBs as the ACE, or the ACE inhibitors. Excellent substitute for the ACE inhibitors, but usually fail the ACE first. And we mentioned doesn't affect the bradykinin levels like the ACE inhibitors do, and that's why the side effects are reduced as far as the cough and the angioedema, but there still is a possibility. Adverse effects, similar to the ACEs, because they're still acting in the ROS, right? In the ROS system. Lower risk, like we mentioned, still can get that hyperkalemia, so if you have potassium-sparing diuretics or other medications that spare potassium on board, once again, that's a precaution. That increase in BUN and serum creatinine can happen just like with the ACE inhibitors, because a lot of the actions are the same. Just further downstream is where the receptor for the medication is. Caution with renal stenosis, but not an absolute contraindication like it was for our ACE inhibitors. Same thing for pregnancy, though. It's a no-go. ARBs, just like ACEs, contraindicated. Same drug interactions. Anything that's going to increase serum potassium levels, we have to be careful because of the aldosterone decrease affecting the potassium excretion from the kidneys. Renal trifecta still in play. Same for ACE and ARBs with an NSAID and a diuretic. Do not use ACEs with ARBs. Do not use with ACE with an ARB. You're going to see this on boards. It's ACE or ARB, not together. Those two things together can have some really fatal adverse effects. No added benefits, but now you're definitely going to give your patient hyperkalemia. So you can affect the kidneys themselves and also the excretion of the potassium. So no ACEs with ARBs. So if you see those two suffixes that we pointed out together, you know that that's the problem. Moving into our last medication that's in our first line, or our backbone. Notice beta blockers. We're not talking about that being a first line medication for hypertension, although that's the first one people always think of. It's not first line. So calcium channel blockers are one of the four major ones, first line for hypertension. Very effective for blood control. We usually think about our calcium channel blockers more so for specific populations. Two major classes you need to be aware of because their MEC action is very different, or where they most likely cause their effects. And on the left, they're easy. The dihydropyridines end in pine. And I mentioned on Friday that DHP, or dihydropyridine, is just an organic compound. It helps with oxidation. You don't need to know the MEC action. I've tried to read up on DHP, dihydropyridines. I still don't know what they are. I'll be honest with you. I still don't understand it. I've read them numerous times. But I do know the difference between DHP and non-DHP calcium channel blockers, in that DHPs end in pine. And their MEC action is different, right? Once again, calcium channel blockers, the pines, the DHP calcium channel blockers, are first line in hypertension. Unlike the non-DHPs, they have more specific roles. So for our pines, or our DHPs, they are going to act primarily on vascular smooth muscle, causing vasodilation, minimal action on cardiac tissue. That's our pines. vasculature. It's vascular smooth muscle. The non-DHPs, the two big players are listed there for you, verapamil and dialtazam, more effect on the heart. More effect on the heart. We're going to talk about the specific mechanisms coming up on some slides and what they do, but they kind of have the same actions, just at different locations in the body, right? Because the non-DHPs, more heart. And you've talked about them, right? Didn't you talk in last block about either verapamil, dialtazam, when you start talking about rate control for the heart, right? So you should remember that class of calcium channel blockers are going to have more cardiac effects, both on the rate, the heart rate, and also that ionotropy, right? How hard the heart's pumping, or the force of contractility. So left side, pines, first line of hypertension. Right side, no. Niche roles because of their cardiac specific activity. All of the calcium channel blockers are going to block the inward movement of the L-type calcium channel. So calcium moving down the L-type channel. So calcium, if you remember, calcium entry required for smooth muscle contraction and cardiac contraction. So the CCBs, the calcium channel blockers, block that action because it doesn't allow the calcium to move down the L-type calcium channels. Make sure you understand the mechanism of action of all of the first-line medications for hypertension, what makes them different. And as I said, the DHPs, or the dihydropyridines, indapine, strong vasodilators, minimal direct cardiac effect, but you can get reflex tachycardia. Why? Because of the vasodilation, right? Non-DHPs, they're going to have their negative inotropic and chronotropic effects on the heart. They're cardioselective. So they're useful for rate control and arrhythmias. Second line for hypertension. Make sure you have that down pat. Who do we use our calcium channel blockers with? We talked about ACEs and the compelling indications. Now for our calcium channel blockers, if folks have hypertension and they also have asthma, diabetes, angina, or chest pain, right? Or some specific arrhythmias, which you've already looked at last block, those arrhythmias that we can use the non-DHPs for. Also, we talked about our fourth class of hypertension, right? We had our stage 1, stage 2, our pregnancy, and then we had that isolated systolic hypertension. Remember that? That slide's going to come back here in a bit when we start going specific treatment. Well, that's where we're going to use our calcium channel blockers first line, that isolated systolic hypertension. And if you remember that, it's a blue slide with the different boxes. Calcium channel blockers was the only thing on the slide for isolated hypertension. Isolated systolic hypertension. Now, this is the drug class that the literature sometimes will still reference has more efficacy in our African American population than the ACEs. But both are considered first line. We didn't talk about calcium channel blockers with stars for heart failure, right? Was there any stars for calcium channel blockers on this slide 2 ago? No. Why? Because calcium channel blockers are contraindicated in heart failure. And we'll talk more about it when we get into the heart failure specific lecture. We have an entire lecture on heart failure, but calcium channel blockers generally contraindicated. Amlodipine, you will see in the literature, amlodipine is the one calcium channel blocker that supposedly can be used safely for hypertension with heart failure. However, look at the last bullet there. Recent studies shown 38% increase in risk of heart failure with amlodipine versus a diuretic. So I, as a primary care PA, wouldn't be throwing amlodipine at a heart failure patient. That would be the cardiologist. And generally, even though amlodipine is touted as safe, some studies have shown maybe not so. So that's why I'm not giving you the medications in this class that we can use in heart failure. specifically in heart failure with reduced ejection fraction. And we're going to talk about that in a future lecture. And it says here, like I said on the slide, more efficacious for hypertension treatment in our African American population. You still may see that show up, but remember, we can still use our ACE or ARBs as a first line in that population. So the pharmacology, adverse effects. Well, think about what the drug does, right? These are the DHPs. They dilate in the peripheral vasculature, smooth muscle, right? So peripheral, anytime you're going to dilate, what can happen? More fluid stays there. So peripheral edema, ankle edema, flushing, dizziness, headache, fatigue, constipation. There's a unique side effect of nifedipine that the boards love, that it causes gingival enlargement. Yes, it's somewhat trivia, but it's an adverse effect that's unique to this class, unique to one of the pine, one of the DHP calcium channel blockers, gingival enlargement. So enlargement of the gums, right, in the gingiva. But the other adverse effects are pretty common. There's a note to avoid high-dose, short-acting calcium channel blockers because of an increased risk of MI. Because too much of a good thing, right? So too much vasodilation with a marked reflex tachycardia can cause an MI. So an example I give you there is the same medication that is the caveat for the gingival enlargement, nifedipine, immediate release. It has immediate release packaging and product. And with immediate release, you have to be careful because of what the bullet says. High dose, short acting, quick dilation, excessive vasodilation with marked reflex tachycardia can lead to an MI. A lot of times your stems, your vignettes for the adverse effects of calcium channel blockers is going to talk about the fluid, right? Ankle edema, flushing, headache. Drug interactions, we have to be, even though it's still a first line, and we talked about using 2 from a first line, right? When we get to stage 2 hypertension, pulling back on Friday, 1 drug from the 4 options for stage 1, 2 drugs for stage 2. We still have to be careful and watch for, that combination effect of medications that can cause orthostatic hypotension. The other drugs that are first line. Anytime you're going to start combining drugs for hypertension, if you decrease in fluid or leading to hypovolemia, you have to be worried about orthostatic hypertension. It's not a contraindication, it's just to be aware that when you put an ACE or a diuretic or a beta blocker, which we'll talk about in a bit, on board with a calcium channel blocker or any combination of those, a drug interaction to watch out for is going to be hypotension, right? Orthostatic hypotension. So DHP CCBs are affected by the CYP3A4 inhibitors and inducers. Probably heard that CYP3A4 inhibitor list a bunch, right? Everybody's tracking what they are, the big players, right? Those macrolide antibiotics, some antifungals. Everybody's remembering all that? I'm assuming yes, even though I'm not getting many nods. I know that you've had it. So just be aware. And then grapefruit juice, right? Same thing, inhibiting CYP3A4. So what happens there is going to dangerously, any of those are going to possibly dangerously increase the levels of the DHP CCBs that hang around, not being broken down. There's some inducers. You probably haven't talked that much about them, but like rifampin. Have y'all talked about the CYP3A4? Okay. I'm assuming everybody's tracking it, so not going to get real specific. Just know CYP3A4 inducers or blockers are going to affect calcium channel blockers, specifically the DHPs. So correction on this slide. We're going to talk about the non-DHPs, which aren't really an adrenergic system blockers. So everything after the non-DHPs are, and we'll talk about what they are, but basically anything from this point forward is not in our first line, is the caveat there. But not all of them are adrenergic system blockers, truly. Most of them we're going to talk about are, but I would not categorize the non-DHPs as adrenergic system blockers, so just be aware. But you need to know is what's underlined is everything from this point forward in the lecture is second line, not in our first line. And that should be easy to pick out as long as you know what's in the first line. So the non-DHPs, the non-DHP calcium channel blockers, they don't end in pine, right? So really only two drugs to talk about, dialtazam and verapamil. So when you compare dialtazam to verapamil, you'll see their effects there in the chart on the bottom, right? So with the down arrows, if you got a double one, that means more. So for heart rate with the verapamil, probably decreases it more than the dialtazam is what that's indicating. Same with AV node conduction, same with myocardial contractility, and then they're both the same for arterial vasodilation. So, and they both have significant effects on both cardiac and vascular smooth muscle. And you talked about in block 3 when we would use them, right? The different medications, and there's the clinical use there for verapamil on the left and for dialtazam on the right. So angina, SVT, kind of across the entire class of non-DHPs. And then we talked about verapamil last block and how it's in that prophylactic class for migraines and cluster headaches. And so the main take-home point is with the dialtazam, there's a little less pronounced negative inotropic effects compared to verapamil. But both of them are going to more affect the heart than peripheral vasculature calcium channels, which is what we see with our DHPs. So the adverse effects, know that verapamil can cause constipation. It's a new one. It's a nuance, right? But the boards like to test it. We have to monitor for bradycardia because we talked about the non-DHPs have a more effect on the cardiac tissue, those L-calcium channels. And you see the third bullet, adverse effects for the non-DHPs, worsening heart failure. That's why we didn't give you any CCBs, either DHP or non-DHP for heart failure. And you'll understand that more as we build on this lecture through the future ones. We can also get some gingival hyperplasia with the non-DHPs. But I gave you one that specifically to know from the DHPs. Drug interactions, same deal, right? Orthostatic hypotension when you're using anything that's going to possibly cause hypovolemia together. The non-DHPs can cause increased digoxin levels, and then we also have the same CYP3A4 interactions. Grapefruit juice is still there. For the non-DHPs, beta blockers can have an additive negative inotropic effect, bradycardia. In general, a specialist may, but in general, do not combine non-DHPs with beta blockers. And we're going to talk about beta blockers coming up, but that negative inotropic effect that happens when you put those two classes together can cause too much of a decrease in the heart rate and the contractility force of the heart. DHPs, on the other hand, because they are not specific to the cardiac calcium channels, you can use beta blockers with DHP, calcium channel blockers, safely, but not the non-DHPs. And it makes sense when you think about, especially if you're using a beta-1 selective beta blocker, which is affecting more of the heart. So here's a new one you may not have heard of, but not in our first line, right? It's not on our overall slide of our first lines, but aliskiren is a direct renin inhibitor. So now we're going even further up into the Ross system, right? If you think back to that normal physiology, when we started talking about what happens, what renin does, right? So it's higher up in that cascade of the Ross. So above the ACE inhibitors and above the ARBs, the direct renin inhibitors directly inhibits renin. So you should understand that mechanism of action pretty easily as long as you know the one drug we mentioned in the class. So even though it directly inhibits renin, that means you're going to prevent angiotensinogen from becoming angiotensin 1, right? Whereas the ACE inhibitors, angiotensin 1 to angiotensin 2 blocked, whereas ARBs are blocking the angiotensin 2 receptor. So way up higher, you would think it'd be great, right? Because we're decreasing renin, we're stopping the angiotensinogen from the liver from becoming angiotensin 1. However, it's not first line. And that's going to be the adverse effects, right? Diarrhea, headache, dizziness, cough, back pain, and it doesn't have as much efficacy. Do not use a direct renin inhibitor with an ACE or an ARB. So it was nowhere in our first line discussion. It's a second line consideration, but don't combine it with ACE or ARBs. Usually, when will you see this medication used? So if you can't, we're going to start with an ACE. Can't handle an ACE, go to an ARB. ARBs don't work, can't handle an ARB, then we may consider the aliskiren, the direct renin inhibitors. So usually this is going to be failure of both the other two first line classes, ACE and ARBs. Do not use it with diabetes, severe kidney disease, due to risk of kidney failure, low BP, and hyperkalemia. So some of the indications for ACEs are here, but you don't use those same indications for aliskiren, right? So kidney disease and diabetes, they're not utilized for those patients. And then once again, avoid potassium supplementation because the aliskiren or the direct renin inhibitors, once again, could lead to hyperkalemia. And I mentioned the side effects to you. So a new second line class, alpha-1 adrenergic blocking agents. What do? They selectively block alpha-1 receptors and prevent vasoconstriction. They relax arterial and venous smooth muscle, decreasing peripheral resistance. Not a first line medication for hypertension. They're niche roles. We use alpha-1 blockers more for BPH, folks with hypertension and BPH, not a first-line med. It's usually never used in monotherapy for hypertension. Like I said, that niche role is usually a hypertensive patient with BPH, benign prostate hyperplasia. You can combine it with some other medications for resistant hypertension, but we're not going to get into that specialized clinical management. Just know it's a second line agent. And upcoming slides will tell you what they are, right? So prazosin or mini-press, you might have heard about it in psych, right? Did y'all talk about prazosin for PTSD? And that's its indication in that packaging, right? Is prazosin for PTSD. And then we have uroselective agents like the other two listed there for BPH, not for hypertension. The tamsulosin or Flomax is the one you hear of a lot, or silodosin, Rapaflo. So those are going to be more for the BPH and the uroselective alpha-1 blocking. There is an adverse effect you need to be aware of. Did y'all talk about the first dose effect in your BH lectures with prazosin or tamsulosin or Flomax? So there's a first dose effect from these medications, from the alpha-1 adrenergic blockers that the boards love to test you on, right? So where a patient faints after the very first dose that they take, they get rapid onset orthostatic hypotension. Know that that is an adverse effect possible for this drug class. Boards do love to test you about it. The first dose effect. Take your very first dose, first time of an alpha-1 blocker and syncopal orthostatic hypotension. And then the other adverse effects are listed there. Tachycardia, the reflex tachycardia could cause angina, and then edema from prazosin. The main thing I want you to be aware of is that first dose adverse effect, and then knowing that the alpha-1 blocker or blockers listed on the slide are not first-line hypertension treatment. So then we have our alpha-2 agonists. Did y'all talk about methyl-dopa already? Okay, so it should be a review, right? Same theme, this is not first line. So these are all the central acting agents that we're hitting on now. So methyl-dopa is a central acting. We're going to talk about beta blockers coming up. They're centrally acting. Any of the central acting medications, usually not first line for hypertension. Usually it's specific comorbidities. And what do they do? All of the centrally acting adrenergic drugs reduce blood pressure by decreasing sympathetic outflow. At least all the ones we're going to talk about. So the methyl-dopa is going to stimulate the presynaptic alpha-2 receptors in the CNS. So that inhibits sympathetic outflow to the heart, to the kidneys, to the peripheral vasculature. So the net effect of an alpha-2 agonist is peripheral vasodilation, which decreases blood pressure. What you need to know about methyl-dopa, pregnancy. That is when we're going to think methyl-dopa. One of the 3 medications that we're going to say, and normally the boards are going to ask you like, patient is hypertensive and recently found out to be pregnant. She's on an ACE or an ARB. What medication do you switch her to? Methyl-dopa being the main one. Usually the patients are switched to. And we'll talk about a couple of others and what class they're in. So the reasoning is because just like diuretics in hypertension, methyl-dopa has the longest track record, right? More testing has been done on methyl-dopa than the other 2 meds we're going to talk about for hypertensive patients that are pregnant. So know that methyl-dopa is an option for our hypertensive patients that become pregnant. We also are going to talk about later in the lecture hypertensive urgency and hypertensive urgency and emergency, and we'll talk about methyl-dopa's kind of a niche role there. Adverse effect, anticholinergic side effects, right? Dry mouth, sedation, constipation, you should be very familiar with those. And then we can have some mental status changes, impaired mental concentration, mental depression, nightmares with long-term use. Main thing I want you to know is its class, what med it is, and pregnancy. Now we're to the beta blockers, not a first line. One of the most misunderstood drugs in hypertension. When you talk hypertension, everyone always talks about a beta blocker or brings it up. Not a first line medication. Niche roles for the beta blockers too. And the reason that people think of them so often is because the comorbidities that folks have with hypertension, we do treat with beta blockers. So a lot of times we're doing an association thing. Oh, they have hypertension, they're on a beta blocker. Yes, because they have hypertension with some other compelling indications is why they're on the beta blocker, not as a first line for their hypertension. So much like the DHPs and the non-DHPs and calcium channel blockers, when we talk beta blockers, we have some that are more cardioselective than others. And those are the beta-1 selective antagonists. So the beta-1 selective blockers on the left, they affect mainly the beta-1 receptors on the heart. So make sure you're keeping those separate when we talk about DHP, non-DHP calcium channel, or then when we talk about selective, non-selective blockers for the beta blockers. So you'll see, I think it's on your memory jog slide, like the beta 1 selective ones, like they go up to like M in the alphabet, if you want to quick down and dirty, as long as you're not considering the mixed ones that we're going to talk about. There's only a couple, or the intrinsic ones, but they go up to M in the alphabet for the beta 1 selective, whereas N and above for the non-selective, except for the specific ones on the right or left. Why does beta selectivity matter? Well, it's going to matter a lot for comorbidities, especially your patients with asthma or diabetes, because if you're doing the more cardioselective, it's not going to affect their underlying disease process as much, or the medications that they're on for their asthma or the diabetes. And then we're going to talk about the medications that are mixed, the labetalol and the carvedilol, and then the intrinsic symptomimetic activity beta blocker agents. There's only a couple there, and we'll talk about their specific use. So definitely kind of a lot to put into different buckets, but you need to know the differences when we talk beta 1 selective blockers or antagonists versus the non-selective versus the mixed and non-selective, and then the ISA medications. And we're going to talk about the niche roles of each major class. So the intrinsic symptomimetic activity, that's just saying that these beta blockers are partial agonists. They're not a true antagonist. You're getting some beta block and you're getting some agonist activity with the partials. So when are these medications useful? So the ones with ISA are options for patients who may need a beta blocker but experience significant bradycardia from the non-ISA. So the non-ISAs won't give you such profound bradycardia as the other classes, either the beta 1, mainly the beta 1. We avoid medications in this class post-MI, this class meaning the subclass of beta blockers. So the ISA beta blockers we do not use post-MI. And we're going to talk at length post-MI in our acute coronary syndrome or an angina lecture that we do use beta blockers. It's like standard of care, but we don't use the ISA ones post-MI. Just know as a coming attraction that the ISAs don't have the same mortality benefit as the other beta blockers post-MI. So I think this is a good spot to take 10, and we'll pick up and finish this lecture up. There. Thank you. All right. So we're continuing with the beta blockers. What do? They're going to reduce blood pressure by decreasing the heart rate, decreasing the contractility of the heart, reducing cardiac output, and they also suppress renin release from the kidney. So this leads to lower angiotensin II and aldosterone. So a lot of the same effects that we saw with agents that act in the ROS system. What does that mean overall? Beta blockers indirectly influence both cardiac output and peripheral resistance. And you can see the clinical outcomes that can be caused in blood pressure reduction, both systolic and diastolic, there at the bottom of the slide. Clinical use: angina, arrhythmias, heart failure, and we are going to have our specific agents for heart failure that we'll talk about specifically in the heart failure lecture more in depth. Post-MI, as I mentioned last hour, hyperthyroidism, you should remember that we utilized, which beta blocker did we say mainly? When we start talking hyperthyroidism, anybody remember when we started talking about thyroid storm? There was a beta blocker that we put on board for the adrenergic symptoms. Yeah, propranolol, exactly. So coming back, right? And then migraine prevention, which we talked about last block as well. And then for heart failure, there's really only 3 medications you need to know of from this class, from the beta blockers, and that's metoprolol, carvedilol, and bisoprolol. But you don't need to memorize it now. We're going to talk about them in upcoming lectures, but just know there's 3 of the beta blockers that we utilize So one of them's a mixed, and then two of them are the beta 1 specifics, right? Or the beta 1 specific beta blockers. But there are three. And then you'll see at the bottom of the slide, we talk about the lipophilic agents enter the CNS better may result in more cases of those mental changes, drowsiness, mental confusion, nightmares, depression. Therefore, the beta blockers with lower lipid solubility have a better CNS side effect. So the higher lipid solubility drugs, propranolol and bisoprolol, are listed there, and they may cause more of the CNS side effects mentioned on the slide. So precautions. We talked about last block, right? Or Major Hart did, that the beta blockers can mask hypoglycemia in diabetics. We can also cause some action of bronchoconstriction for our asthma patients, right? So non-cardioselective beta blockers can make bronchoconstriction worse. So we have to be careful with our asthma patients, and if they're already on a bronchodilator, we can affect the action of that medication when we put a beta blocker on board because they're in direct antagonism, right? Lipid abnormalities can be affected by beta blockers. And then abrupt withdrawal of beta blockers can induce angina, MI, even sudden death for patients with this ischemic heart disease. So abrupt withdrawal for beta blockers comes up on boards a bit. So you can have rebound hypertension, angina, and an MI. So too much a good thing from beta blockers can give us our adverse effects. The hypotension, dizziness, bradycardia, fatigue or weakness, and also some sexual dysfunction, which we have to discuss with our patients, a possible decreased libido or erectile dysfunction from beta blockers. So definitely be aware of and be able to recall the precautions and the adverse effects for beta blockers. As a class, not specific to, yes, sir?
So with all these adverse reactions and it's non-discriminatory between non-selective and selective beta 1, beta 2?
These are non-discriminatory. Obviously, it may be one of the side effects maybe more with the beta 1 selective versus others because like with asthma, for example, if you're using a beta 1 selective, lower risk, but still a risk. But here we're talking as a class, yes. Drug interactions, beta agonists, like I just mentioned, maybe your asthma patient's on a bronchodilator, on a beta agonist, well, a beta blocker is going to compete for it. You can, and I already mentioned earlier, if you put a calcium channel blocker on board with a beta blocker, severe bradycardia can be a side effect. If you're using it with those cardioselective non-DHP calcium channel blockers, and the two that we mentioned, verapamil and dialtazan. NSAIDs may impair the hypotensive effects of beta blockers, so that's a drug interaction. And then clonidine. You talked about clonidine back in Pharm 1, right? So yes, it can be used as an antihypertensive, but clonidine is last line, last ditch, way down on the list. It's alpha adrenal receptor agonist. It really, clonidine, hypertension if all else fails. But just know it can be a drug interaction with the beta blockers. I'm not going to ask you about the effect, the central acting effects of clonidine and alpha adrenal receptor agonists when we talk antihypertensives. You were tested on it in Pharm 1, so you should know it moving forward, but I'm not going to dig into it. So here are mixed alpha-1 and non-selectives. You only have two in the class. If you go back to the overall slide on the beta blockers, and that's labetalol and carvedilol. So what do? They alpha block and they're non-selective beta blocking. So the actions are listed there. In hypertension, what happens with these medications? Decreased rate and strength of contraction of the heart. But as I mentioned last hour, you don't have as much reflexive vasoconstriction because of the alpha-1 antagonism, because it's a mixed beta blocker. Mixed beta blocker with mixed alpha-1 blockade. So in CHF, decreases afterload but inhibited the vasoconstriction. Once again, that's due to that mixed effect with the alpha-1 antagonism. Adverse effect of the mixed class, bradycardia, and then same precautions as we said for the entire overall class, right, of beta blockers. Caution in diabetics and bronchospastic disease, i.e. asthma. Any of the medications that we use for hypertension, too much of a good thing, can of course cause hypotension. And I mentioned the drug-on-drug interaction when we start talking about anything that's an antagonist. If we have agonists on board, they're going to be in direct competition. And I also mentioned the combination with the non-DHPs, which are cardioselective, with the mixed, or actually with all of the beta blockers. You can get cumulative negative inotropic effect, i.e. Decreased rate and decreased contractility of the heart. So here's your two main players in this class for the mixed alpha-1 and non-selective beta blockers. Carvedilol and labetalol, blocking alpha-1 and the beta receptors. So gonna prevent that reflexive vasoconstriction that we see with the other beta blockers. But they still lower heart rate and they still decrease contractility of the heart. Carvedilol, we're gonna dig in deep when we get into heart failure. That's your cornerstone for heart failure, is the mixed alpha-1 non-selective beta blocker, carvedilol. And you'll see they're under CHF, mainly used in patients with both hypertension and heart failure. Why? Because the data shows decreased morbidity and mortality with heart failure and hypertension from this class of beta blockers, and specifically carvedilol from this class. Labetalol, this is our second drug that we're going to talk about. Pregnancy, good. Can use labetalol. Can use labetalol. And we're going to talk about labetalol in hypertensive emergencies as well. The slide says it's off-label second-line agent during pregnancy, because I told you methodopa is going to be our main go-to, but labetalol can still be used. That's our second of our three that we're going to talk about that we can use. And then hypertensive emergencies, we're going to talk a lot labetalol for severe hypertension or hypertensive emergencies, the IV dosing of labetalol. Now we're talking about direct arterial vasodilators. These become really important in angina or acute coronary syndrome, right? Nitrates like nitroglycerin or hydralazine. But basically, hydralazine and the nitrates are going to directly relax arterial smooth muscle. You're never going to use a direct arterial vasodilator alone. You've got to put something else on board to counter some of the adverse effects, and we're going to talk about that. Basically, the reflex tachycardia that happens with direct arterial vasodilation. For the reflex tachycardia, we're going to put a beta blocker on, and you get fluid retention because we're dilating those vessels or the arterioles, the arteries, arterioles very quickly, very rapidly. So fluid can be retained. So we're going to put a diuretic on board when we use them as well. So any of your direct arterial vasodilators know that we're going to put a beta blocker on board to counter the reflex tachycardia, and then we're going to get a diuretic on board to counteract the fluid retention that happens with the direct arterial vasodilation. There's some combination meds we're going to talk about in angina. So this is just a preview of coming attractions there when we talk clinical use. We combined isosorbide dinitrate and hydralazine. So both of the direct arterial vasodilators at the top of the slide with a medication called Bidal. And this medication, this combination is very beneficial for our African American populations with hypertension and heart failure. So unlike where I said when we talked about hypertension and the calcium channel blockers and the ACEs, this is a case where our specialized a unique demographic does benefit more from certain medications. But once again, this is just a preview. We're going to dig deep into that when we get into the heart failure or the angina and acute coronary syndrome discussion. And there at the top of the slide, we said it's an adjunct agent these vasodilators, adjunct agents, like a beta blocker has to be brought on board to prevent that reflex tachycardia. And then hydralazine is the third medication that you could put a check mark by pregnancy. Once again, second line, but it is used in pregnancy, the hydralazine being it. Hydralazine is okay in pregnancy, and we're going to sometimes use hydralazine in hypertensive emergencies, and we'll talk about that in the upcoming slide. But that's our third medication that we can use in pregnancy for hypertension, hydralazine, not first line. This is just the compensatory responses from the vasodilators that we talked about on the last slide. And then the number one, where you see that's where the beta blocker, that's where the diuretic is acting to counter that effect of a direct arterial vasodilator. And then the number two there is showing why we put the beta blockers and where they act on board with a direct arterial vasodilator. So basically just a picture of what we just discussed and telling you the specific mech action. Be familiar with it, but I just need you to know the things that can happen, i.e. the tachycardia and the fluid retention with a direct acting vasodilator, and then how do we counter that on the slide, right? Diuretics and beta blockers. Same concept on the first bullet, right? Beta blockers to reduce that cardiac stimulation that happens with a direct arterial vasodilator. And then the diuretics reduce sodium and water retention because renin is activated. Adverse effects from the direct arterial vasodilators. Increase plasma renin concentration so we can retain sodium and water retention, right? That's why we're going to get the diuretic on board. And then headache, tachycardia, nausea, sweating, arrhythmias, and angina. Like I said, we'll dig deeper into the direct arterial vasodilators in the angina and acute coronary syndrome lecture. Back to treatment. We talked in depth about the medications, which are first line, which are second line, some special utilizations for each. So we're back to where we started, right? And we talked about the 2017 guidelines. In red there is the note that I've mentioned to you, 2025 updated AHA, ACC guidelines, and they're in the FYI section following the memory jogs. However, our categorization of stage 1 and stage 2 from 17 to 2025 has not changed. So we utilize, whether you look at it 17 or 2025, the same systolic blood pressure and diastolic blood pressure numbers to differentiate between normal, elevated, and then stage 1 and stage 2 hypertension. So those are the numbers I mentioned you need to know. It is important to know that this is based on an average of 2 or greater careful readings obtained on 2 different occasions. When you're out in practice, some of you may have done this, or personally you may have had some issues with blood pressure before, but a lot of times you'll have, especially like in the service, you'll say, hey, we're either doing a 3-day or a 5-day BP check. Come by the aid station, come by the MTF, go to your primary care, same time of day, 3 to 5 days in a row, and you're keeping a blood pressure log. Because one moment in time, you cannot say, oh, you have stage 2 hypertension. You got to have a log showing, and it needs to be done in a careful clinical situation or a careful reading, usually about the same time of day, because we talked about those fluctuations in blood pressure in lecture 1, right? On Friday, that while we're sleeping, it's really low. Then in the morning, it's probably a little low, but it can climb up, and different folks have different blood pressure readings at different times of the day, based on diet, based on what they're doing, based on their mood. So it's usually better to do those logs a couple of times a day or at the same time of day, 3 or 5 days, but based on an average of greater than or equal to 2 careful readings on greater than 2 occasions. But normally you'll see folks do a diary or a clinic check 3 or 5 days, which is greater than 2. But like I said, remember the classifications, whether you're talking 17 or 2025. Goals, the same, right? From 17 to 2025. The only difference I've mentioned is that with those compelling comorbidities, the 2025 guidelines said, yeah, 130 is good, below 130 is really good, but how about we try to get to 120? How about we try to get those folks with other comorbidities all the way down to 120? So that's the only big difference, other than they wanted to rename the CV risk calculator. Now it's called Prevent, and Prevent just has more information for your patient to fill out. It digs deeper into demographics, basically. More categories to come up with the risk of having an acute coronary event within the next 10 years. I mentioned to you on your test, I'm not going to utilize the ASCVD percentage as a standalone, you must know this category to start treatment. It's going to be there to assist you, but you really shouldn't need it. It's just there to get you used to seeing it. Back to our first slide, and we've talked about this entire slide. Each of the first line medications, if you have stage 1, know those numbers. Know you can ignore the calculate ASCVD risk, but now it's calculate prevent risk. But the take home on the 17 guideline was less than 10% on ASCVD lifestyle modifications, which we're going to tell any of our patients that are hypertensive anyway, or either borderline. But greater than 10, and in our cases, if you're in stage 1 with those systolic or those diastolic readings, choose an agent from the 3 listed. And know the agents from the 3 listed, the differences, right? Whether specifically, like when we're talking the calcium channel blockers, is it just any calcium channel blocker? Or is it a non-DHP or a DHP? DHP would be the right answer, right? Non-DHP had the specific indications that we talked about because of how they act on the cardiac tissue more so than the DHPs. Stage 2, pick 2, just add on. And then know, like I mentioned, you can't use, it's ACE/ARB, that doesn't mean ACE and ARB, ACE or NARB. And then pregnancy, there's your 3. We talked about, I don't think we talked about the nifedipine, but that was your 3rd one, and then the hydralazine is an off-label use. But number 1 and number 2 are the more likely used medications for pregnancy. And then I mentioned the calcium channel blockers. There's only one drug class for isolated systolic hypertension, and that gives you your indications and your systolic and diastolic measurements there on the far right. So treatment is individualized, right? We talked about needing to think about individualizing the medications based on compelling underlying disorders. Key considerations, you got to think about diabetes, you got to think about chronic kidney disease, proteinuria, pregnancy, history of stroke, and then ASCVD risk or now prevent risk. Most patients are going to require 2 agents eventually. Usually you're not going to get that patient and you go, okay, we're going to put you on hydrochlorothiazide, and then they're going to do lifestyle modifications and they're just going to be on a diuretic for perpetuity. Usually that's not the case. Maybe there are cases for sure, but usually you're going to, blood pressure as they age, we get the stiffening of the arteries, it's going to creep up, and then we're going to move into stage 2. And there's some indications there just highlighting not everything you need to know about those underlying disorders, but some that we mentioned and which medications we can use. And like I said, for pregnancy, methodopa, nifedipine, and or labetalol, and we mentioned hydralazine being another agent, but that's off-label use as well. And then for secondary stroke prevention, we want to avoid CCBs. Usually, non-adherence is one of the major causes of our patients not responding to our antihypertensives. Usually, non-adherence to the medications is a common cause of uncontrolled hypertension. So how do we get after that? Right? Simplify the regimen. We talked about on the slides where we have combination meds. So if they're stage 2 or above and we're using a diuretic and say an ACE inhibitor, well, once you get them titrated, use the combo pill because it's easier. Your patient will be more compliant taking one medication versus 10, whatever the case may be. So simplify the regimen. Try to use long-acting drugs if your patient can tolerate it versus having a dose in the morning and in the evening. Try to get them on one a day that lasts for 24 hours. And obviously looking at your side effects. If your patient starts having side effects, look at the combination of the meds that they're on and see if there's a way that you can lower their side effect profile by possibly changing medications or alternating between things in the first line medication classes. And then always, it's real world, right? You've got to build some trust with your patient. You have to be an empathetic provider, talk to them about the fact that yes, hypertension probably going to be a long-standing issue that you have to deal with, but we're going to work through it. We're going to give you the best advice we can, and we're going to try to minimize side effects. Make the dosing regimens as easy as possible. All those things, right? So definitely just think about the improving adherence when you have those chronic hypertensive patients. Severe hypertension and hypertensive emergency, we are going to hit on it briefly, but you're going to have it again in the EM, right? Senior semester, you're going to have severe hypertension, hypertensive emergency. You might have heard in the past severe hypertension called hypertensive urgency in the past. You may still see it in some older textbooks, but now it's severe hypertension, versus hypertensive emergency. And you can see the indications based on the systolic or diastolic blood pressure. The main differentiator is end organ damage. It's an emergency if your patient has those levels of elevated BP, systolic or diastolic, and they have acute target organ damage, right? So if they have end organ damage, then we're going to get them into the ICU. We're going to get them on IV meds. There is an option for non-IV meds, obviously down in hypertensive urgency. For urgency, normally we're going to try to give the patient, either get them started on blood pressure medicines or get them taking their blood pressure medicines they're already supposed to be on, making them compliant. But if there's no end organ damage, we don't have to go to the ICU. We don't have to go specifically just parenteral, which we have to do for the hypertensive emergency, right? So what will we see with end organ damage? What are we talking about, right? Let's just start naming some things. Hypertensive emergency. What would you see? End organ damage. Loud? Blurred vision. Yeah, what about some things with the ophthalmoscope? We see any things with that sometimes? Right? So encephalopathy signs, right? Headache, confusion, agitation, seizures, altered mental status. What about stroke-like symptoms, right? End organ damage, yes, a stroke, intracranial hemorrhages, so focal neurological deficits, sudden weakness, speech problems, visual changes. And then, like I mentioned with the eye exam, right? Papilledema, that swelling of the optic disc, which you can see with your fundoscopic exam. So I'm not going to ask you to come up with all the different things that can be signs and symptoms of end organ damage for severe hypertension or hypertensive emergency. Just keep in mind what they would be and know that that means we're admitting and we're getting some IV fluids on board. We're not giving PO meds and come and see me next week, right? Outpatient wise. So here's the agents. Some of these we didn't talk about in depth. We did talk about nitroglycerin, so kind of be aware of them. On the next slide, we're going to talk about the agents that you see more commonly that show up on exams all the time, and that is real world utilization for hypertensive emergency. Notice in the top of the slide, this isn't urgency, right? This is end organ damage. This is emergency. And I mentioned to you when we talked about those direct arterial vasodilators, that hydralazine is in that class. And it is preferred for eclampsia or preeclampsia, and it's off-label really for hypertensive emergency. And then the nitroglycerin, everyone's familiar with MONA, right? So nitroglycerin's preferred for an acute coronary syndrome. And we have a lecture specifically on that. And you probably talked about it in cards, and you're definitely going to talk about it in ER and see it out on your rotations. So we're not going to dig that deep. So for hypertensive emergency that show up on boards all the time, it's the bottom two, right? It's the bottom two. Esmolol, labetalol, the beta blockers. Esmolol, ultra short acting, easy to titrate. Labetalol, remember what class it's in, so you don't get the reflexive tachycardia for the labetalol. And labetalol preserves the cerebral blood flow. Both esmolol and labetalol used for aortic dissection, and then labetalol preferred over esmolol for preeclampsia or intracranial hemorrhage. But definitely make sure you look at the adverse effects and the notes there for the esmolol and labetalol, and think about what class of beta blockers they are, to why one would be preferred over the other, specifically why the labetalol is preferred lowering BP without a reflexive tachycardia and preserves cerebral blood flow. So can counter some of those end organ neurological changes that we were talking about. And this is just breaking those two out. We talked about the mech action, that labetalol being the selective alpha-1, non-selective beta, mixed. Can be used for urgency and emergency when we talk labetalol, because there's a PO, there's a pill version that can be utilized, and then IV, obviously in emergency. And I mentioned not causing reflex tachycardia for the labetalol and not reducing cerebral blood flow. And then the benefit for the esmolol would be that it's so rapid acting, it's easy to titrate the medication. So know the difference between those two in hypertensive emergency. Which brings us to the memory jog. We're not going to go through here, but I will post check on learnings for the hypertension lecture that we did Friday and today, closing it out. And the good news is that as we move through, the next lecture is going to be diuretics, which is going to include a lot of the things that we discussed with thiazides and thiazide likes, but then adding in a few more classes and talking about the difference. And then it'll build. So a lot of the medications that we're going to talk about finishing this block over the next 6 lectures are all going to build on what we talked about in hypertension. We're just going to talk about specific uses in heart failure or angina, or and then hematologics is its own thing, and we'll work our way through that at the end of the block. So I'll post the questions this afternoon, and I think we have a standing date for 1300 from here till the perpetuity of this block. Thursday, for both classrooms, Thursday the 6th, this Thursday, I will be out. We have plenty of time for the block. We don't have to add or move or add another lecture. We just won't have lecture Thursday. If class leaders, if y'all can just coordinate to either have someone else teach in or whatever, y'all do y'all's thing. But I won't be here Thursday. And we'll pick back up on Friday, 2 or 3 lectures next week, and then you have a long weekend to study for that next Monday, and then we're all out of here. All right, thanks.